I'm honored to have with me today Dr. Margaret Fitzpatrick. She's a physical therapist with 29 years of experience and is specialized in orthopedic and vestibular therapy for dizziness and balance disorders. Dr. Fitzpatrick is the owner of both Willow Grove and Hatboro Physical Therapy in Pennsylvania. She's a community educator and frequently speaks on vertigo and has been featured on the network news. Margaret, thank you so much for joining me here today. Our goal is to spotlight clinicians that are making an impact in reducing the musculoskeletal epidemic, one patient at a time. I became aware of your tremendous success and had to share what you're doing so others can learn of these better treatment outcomes. So, Margaret, you specialize in treating vestibular disorders. Can you explain to the audience what is a vestibular disorder, including the signs and symptoms?
Sure. So vestibular disorders are disorders of the inner ear, and the inner ear is responsible for our sense of balance. And our sense of balance comes from our eyes, our ears, and our legs. Most people don't realize the importance of their inner ear in keeping us upright and preventing us from falling. Falls are an epidemic. It's the leading cause of death and disability among seniors. So it's very important to go out and teach community members about their vestibular system. And the signs and symptoms are A, if you're falling, you've got a balance problem. And another big problem is vertigo. So vertigo is a disorder of the inner ear where the person will get in or out of bed, bend over, look up, and the room will spin around on them and they can, wind up falling. So there's treatments of the inner ear. There's mechanical treatments of the inner ear for conditions like positional vertigo. And then there's other exercises for the inner ear for people who just have a weakness or a balance weakness in their inner ear.
Okay, well, what's the traditional process, or I should say unnecessary obstacles that you see with the current care of vestibular disorders, and what are you doing differently?
So, unfortunately, people will have dizziness. They would go to their doctor, and the doctor may or may not be able to identify that they have a really common condition called benign positional vertigo. It's very easy to diagnose if they have it, but you have to have the expertise to know it. But it should be more common knowledge for primary care physicians and internists and even ER doctors, because a lot of times these people wind up in the ER. So unfortunately, people will go to the doctor. They're not really sure what kind of vertigo they have, so they may either send them for more testing that's unnecessary. They'll send them for an MRI or a CAT scan, which isn't going to find this problem in the inner ear, especially if it's a mechanical problem of the inner ear. Even if it's a weakness in the inner ear, those tests aren't going to work and find the problem. And then the other thing that they do, unfortunately, is they just medicate them. They'll give them a sedative to treat the symptoms, but it's not treating the problem. And that only increases their risk of falling. So it's really poor management of dizziness and balance.
Okay, so Margaret, it sounds like if a patient has a dizziness problem or they are suspecting a vestibular problem, they really should be sending them directly to a clinician that can screen it properly rather than medicate them or do unnecessary radiographic examinations.
Correct. There's just, they need to be more aware of the signs and symptoms of these common vestibular problems. And yes, once they've identified that, they need to send them off to a specialist.
Okay,
The physician don't have enough time to be treating this in their office, but they just need to recognize the signs and symptoms of, is this positional vertigo? Does this look like a virus in the inner ear? Or is this something more serious where they do need to go and get those tests done?
so Margaret, what are you doing in your clinic to assess for this? How are you doing it differently?
So we listen to the patient. We're trained. What questions do we need to ask them? Is this positional related? Do you get dizzy when you're getting in and out of bed, bending over, looking up? Is the vertigo, this spinning, short in duration? If it's short in duration and it's positional related, then it's benign positional vertigo. We should check them first for this. There's an easy clinical test called a Hall pike. I'll lay the person down on the table, look at their eyes. Do I reproduce their symptoms, and do they get abnormal movement of the eyes? It's called nystagmus. The eye will just start to spin and twist. If those things happen, you have benign positional vertigo. You go ahead and you treat it, and you can fix it within that first treatment. So the research has shown it's 95% effective in 1 to 3 sessions if it's positional vertigo.
Well,
Then if it's not positional vertigo, Is it a virus? Is the spinning going on for hours? And then you just have to differentiate, is this something more serious like a stroke, or is this a virus of the inner ear? And they present differently. There's signs to look for if it's a stroke. There's going to have different movement of the eye, and you just have to be skilled in knowing which test to run. Is this the inner ear, or is this the brain causing the vertigo?
Wow, Margaret, this is truly amazing. So, if it is benign vertigo, you're able to assess and treat sometimes in the same day. That rings in my
Absolutely.
ears that you're moving away from evidence based medicine to precision care. Precision care is a big deal because you're having that much success. We need to get more patients to clinicians like you then. This isn't evidence based, this is now precision care. If you're able to diagnose and treat that same day, and then rule out if it is something other. Like you can then, your examination can then tell you this is not benign vertigo, this is actually a stroke or a virus. Amazing.
Correct.
Amazing. Yeah. Hats off to you. So, what do you think is the biggest cause of this musculoskeletal epidemic that we have here today in our country?
I think a lot of times we just rush to treat things chemically, or we rush to do diagnostic tests on people when we need to have a more common sense approach for it. So whether it's positional vertigo or it's back pain, they're very similar. They're both mechanical problems that need a mechanical fix. So positional vertigo, it's particles are out of place in our inner ear. We just need to get them out of harm's way and back to where they belong. Same thing with a back pain or a neck pain. Is movement going to make this person feel better? Is movement going to give us a quick change in their symptoms? So instead of just treating the symptom of giving them an anti-inflammatory or a muscle relaxer, should we evaluate people for mechanical issues in their joint as a cause of their symptoms?
And I love
so it's really better clinical evaluations. We're not clinically assessing people. We're just rushing to give them a drug to pacify them.
Mm-hmm. And I love hearing you differentiate that. You touched on a big point when I give talks, mechanical pain versus chemical pain. Two different things. And if we don't know how to assess what's mechanical cause and what's a chemical cause, then we're not treating it correctly. And you just nailed it. If benign vertigo is a mechanical cause, there should be no drugs in that treatment. It should be only a mechanical treatment. Thank you, Margaret, for pointing that out. So if you were in charge of our healthcare system in this country, what changes would you make to address this musculoskeletal epidemic?
So I think the key is education to consumers, warning them about the pitfalls of just taking drugs for their pain, educating physicians that there are other options. Person comes in, you want to help them, but you're not really sure which way to send them. But typically someone goes into the doctor, they're walking out with a prescription. And I just wish there could be a pause before we give them a drug, give them a test, give them an injection, or operate on them and try a more common sense approach. Like physical therapy. It's all natural. There's no harmful side effects like there are with drugs, surgery, and injection. So more education, I think, is key. And physical therapists getting out there more to educate the community about what we do, not only to the community, lay people, as well as physicians.
And I love hearing that again, because again, we go back to your outcomes. Bottom line, if you're able to assess and treat a lot of times in 1 to 3 visits, the cost savings there alone and the fall prevention. So rather than a patient going to a physician that's going to be medicated and then go on for further exams, this is a long process that's taking days now and adding up costs. If physicians could screen if a patient comes in and send them directly to a clinician that is credentialed as you are, it's going to save tremendous amount of time and money on our healthcare system. And then preventing that fall if that person is given a medication that's going to increase their dizziness or their instability. That's, Margaret, what you are doing is amazing. Again, I've heard so much about you in my years and your great outcomes that I had to share this with our viewers. Before we conclude, is there anything else, any other closing thoughts that you would like to tell our viewers and how they can get in touch with you?
I guess the one thing that I always tell patients is the best person that can take care of themselves is themselves. and they need to be more educated, more empowered, not passive receivers of information. It should make sense for them. What am I doing? And then we try as therapists to educate them on what they can do to help themselves, because we don't want them dependent on us. We want them to be able to recognize what the issue is and how to treat it. So yeah, that's the main take-home message. And then people can reach me. I'm very good on email. So it's margaret@willowgrovept.com. And our website is www.willowgrovept.
Dr. Fitzpatrick, this has been very insightful. I know that you're extremely busy, so I want to thank you for taking the time to share how you are making such an impact on reducing healthcare costs by addressing fall prevention and zoning in on the root cause of vertigo and abolishing those symptoms in such a short amount of time. We have a musculoskeletal epidemic, but if we get more people aware of clinicians like you, we can address this one patient at a time. Thank you so much again, Dr. Fitzpatrick.
My pleasure. Thanks for having me.